Today we're going to talk about another component of IV therapy, and that is osmosis and IV therapy fluids. Which type of fluid do I need to give my patient for what is going on with them? This voiceover is, I believe, 26 slides long. It seems that it is pretty long, but students traditionally have difficulty with this topic, so I'm going to just do a brief summary on this PowerPoint, and then in class we'll do activities to try to pull it together for you. Okay, so when we think about body fluids, and if I ask you the question, what is the most important nutrient in life, what would you tell me? I hope that you would be able to tell me that's water, that we all have to have water to survive, right? So what is our primary body fluid? It's also water, and our body is actually composed of about 60% water. Okay, so variations in that can change. Men versus women. Men usually have about 60% total body water, whereas women would have about 50%. So we have just a little bit less than males do. I don't care when you're thinking about this that you're memorizing numbers 50, 60, 45, whatever. I just want this to be in perspective for you so that you know that men have a higher composition of body water versus women, and why do they have a higher total body water than women. Okay, so don't go through here and try to memorize numbers, but just understand why one would be higher than the other. In the elderly, we know that it's about 45%, and when I'm talking about elderly, I'm talking about people over the age of 60. And in infants, we don't talk about pediatrics really in this course. That is covered in your pediatric course, but just to give you perspective, about 77% of an infant's total body is water. And so hopefully you can understand why this would make a child more prone to fluid volume deficits. Okay, when you have that much composition of water, the fluid shifts can definitely affect you. And then a question to think about here, and we'll talk more about this in class. I'll pose this question to you, but think about this. Fat or lean muscle, which one of those contains more water? And in thinking about that, think about this. What do we know about men and women and our makeup of fat and lean muscle? And how would that affect the composition of water in our body? So we'll discuss this more in class, but think about that question. Alright, so there's fluid compartments. Okay, we have fluid that is located in two compartments. One is the ICF, which is the intracellular fluid. The other is the ECF, which is the extracellular fluid. Alright, so intracellular fluid would be fluid where? And extracellular fluid would be where? I'm going to try to show you this in class by drawing you a picture, but intracellular means in the cell. So ICF would be in the cell, and the ECF, extracellular, means that it's outside of the cell, so that would be any fluid that was outside of the cell. Now that fluid that is outside of the cell has three components. Alright, so we have ICF and ECF, and the ECF is broken down even further into three components. We said that it's the fluid outside of the cell. So all of that fluid, there's interstitial fluid, and that is the fluid that is between the cell and the vascular space. Okay, so your vessels. Then there is intravascular fluid, and that is the fluid in the vessels or the vascular space. And then the last one, which doesn't account for a very high percentage of it, but just so you know, it's called transcellular fluid. And transcellular fluid are things like synovial fluids, right? They're very highly specialized. Your spinal fluid, your CSF, is also a transcellular fluid, and they're very highly specialized cells. But that's what that That's what those are, just in case you've heard that. But the interstitial and the intravascular are the two that we'll really focus on. Okay, so how many liters per day is desirable fluid intake? And I know that you guys have had this before, so I'm hoping this is just a quick review. So about 2.5 liters per day is what we really want for intake and output in a 24-hour period. So I want you to think about these questions, and we're going to go over them in class, but I want you to fill these out and think about them. How do we obtain water? How does our body get water? So think about that and bring your answers into class. How do we lose water? Okay, there are two ways that we lose water, sensible and insensible. Sensible means that we can measure it. Ways that we lose water that are measured. And insensible cannot be measured. So there's a couple things that are a couple ways that we can lose water that we can't measure, but we know that we're losing it. So complete this slide, bring it with you, and we will discuss this more. Okay, homeostasis. I know you guys have heard this term before. Homeostasis is what our body wants to do all the time. We want homeostasis. It is our normal function. It's what our body tries to do automatically. Well, it automatically does. It doesn't try. It does do it every day. That's how we function. Okay, so homeostasis. It's dependent on fluid and electrolyte intake, physiological factors such as hormones, age, gender, or organ function, disease state, external environmental factors such as temperature and humidity, okay, and of course pharmacological interventions. We give you medications, and that can definitely affect how our body is functioning. But what we know is that our body always wants to maintain homeostasis, so whatever is happening, our body is constantly trying to stay normal. Okay, fluid transport. Our body fluids are constantly in motion. They are always moving up and down, and you guys know this because you know you have blood coursing through your veins, right? So we know that fluids are always in motion. Your ECF transports your nutrients to your cells and carries the waste away. ECF, it's ever changing, okay? Whatever the environment needs, that's what the ECF adapts to. Whereas the intracellular, it's more stable. It has a more structured environment, so to speak. So I want to mention that whenever we're going through these slides, that don't try to memorize slides and bullet points, but to understand why these things are occurring. Does it make sense to you that the extracellular fluid, which we have already determined is the fluid outside of the cell, which includes the fluid in our vascular system, all right, does that make sense that it transports the nutrients to and from the cells? Well, it should, because that's how blood gets to the cells, right? It goes through the vascular system, it gets to its destination, it picks up the unwanted, it gives the good, and it moves on, just like a truck trading goods of some sort, all right? So when you're thinking about this, I don't want you to memorize. I want you to understand. And does this make sense that this is occurring? Because if you try to memorize these fluids and how they work, you will be lost the entire semester with these fluids. You have to understand, and does this make sense? If I do A, am I going to get the results of B? Okay, so please keep that in mind as we're going through this. Movement of particles through the cell membrane occur 4 different ways, and those 4 are there on your slides: diffusion, osmosis, filtration, and active transport. Okay, so those are the 4 that we'll talk about. The big one is osmosis. The other 3 we'll just briefly mention. Alright, so again, we'll focus on this in class a little bit more, but what is osmosis? And I know that you guys have heard that terminology before. Our cell membranes are semi-permeable, which means that they allow some things, not all things, but some solutes to pass through the membrane. Our cell membrane is permeable to water, and osmosis is the major method of how we transport that water or those body fluids. Okay, so water, which we would consider as a solvent, and I hope that those terms don't confuse you. The solvent meaning that I always try to think of it as it could dissolve it, and then the solute would be the particle, which is getting dispersed or dissolved. So hopefully that'll help you keep that terminology different. But the water, which is the solvent, moves from an area of lesser solute concentration and more water to an area of a greater solute concentration and less water. So I'm going to show you a picture of this in class, but just so you understand that. Do not memorize the definition. Understand it. Okay? This occurs back and forth until equilibrium is established. While this is occurring, it will cause the volume of the higher concentrated area to become higher, and the volume of the lesser concentrated area to become less or weaker. The concentration of particles in a solution, otherwise known as what we call the pulling power, is referred to as osmolarity. So that's the terminology. Osmolarity is the pulling power of the solution. Okay, normal osmolarity of our body, homeostasis, is 275 to 295 milliosmoles. All right, so the number there is 275 to 295. And again, it's not imperative that you understand or memorize those numbers. It's imperative that you understand those numbers, and when we start talking about solutions here shortly, that you understand if the number is higher or lower, in between that, what it would mean. Okay, these are the other three that I just briefly want to mention, and I need you to know the definitions, and I'm sure this is a review that you've heard these. Diffusion, that's whenever you have the particles or the solutes that move freely throughout your solvent. They cross the membrane and they enter into the cell. Okay, they move from an area of high concentration to an area of low concentration. Active transport, that's similar to diffusion, but it requires energy. Okay, so you remember that ATP, Krebs cycle, all that stuff. That ATP is the energy, and that's what active transport. It requires energy to move it across. It moves from an area of lower solute concentration to an area of higher concentration. And then the last one is the filtration, and that's the passage of fluid through the membrane, and it moves from an area of higher pressure to one of lower pressure. So with filtration, we're referring to pressure. All right, so that's the difference there. And just as a note, filtration only moves in one direction, and that's because of the interstitial fluid pressures. So whereas diffusion, fluid moves in all directions, but with filtration, it's just one direction. But I just briefly wanted to mention those definitions to you. Okay, fluid volume deficit, otherwise known as dehydration. So what happens whenever we get dehydrated? Okay, if I ask you that question, I think that you guys would just tell me that we're not drinking enough. Probably we don't have enough fluid, right? So that is the definition of it, loss of fluid from the ECF. Okay, ECF was what? I hope that you can pause this, think about it a minute, and then remember what the ECF was. And I don't mean extracellular. I don't want you to tell me what it stands for. I want you to tell me what it means, right? So what is it? It's all the fluid outside of our cell, extracellular. Hypovolemia, which causes hypotension. Okay, so hypovolemia means we have low blood volume. Alright, so when we're talking about going through our vessels, we have low blood volume. That's hypovolemia. And that blood volume is fluid outside of our cells. So that would stand to reason that it is extracellular fluid, right? Okay, so what happens? I'm going to draw a picture of this in class so that hopefully you'll be able to sometimes visualize that as a little bit better. But what happens is that our interstitial fluid, which we said was what? It's the fluid between the cell and the vascular space. So that fluid is pushed into the vascular space, okay, to compensate for the loss of blood. Remember we said hypovolemia, that's low blood volume. So if we don't have blood going through our veins, then we know we're in bad shape. So we've got to, our body says, hey, we've got to fill up our vessels so that we can have fluid running through there, keep our blood pressures up, right? So it pulls the fluid from the interstitial space into the vascular space. When this occurs, it causes fluid to move out of our cells, because now that we've pulled fluid from the interstitial space, well, what's going to fill that up? So our body says, hey, we got to take fluid from the cell. So now we pull fluid from the cell into the interstitial space. So we've gone from intracellular to extracellular, right? So if I pull fluid from my cell, what's going to happen to my cell? Is it going to shrink or is it going to become larger? That is what is happening with fluid volume deficit. And I hope that you said the cell would shrink. Alright, let's move on. So, what causes fluid volume deficit? Don't memorize these lists. Understand them. Would it make sense that if I had vomiting or I had diarrhea that I'm going to have a fluid volume deficit? Well, of course, I'm getting rid of fluid, right? Would it make sense if I gave my patient Lasix, which is a diuretic, and they were peeing off all this fluid, that I could have some fluid volume deficit? Would it make sense if I cut my leg off and I had a massive hemorrhage that I would have fluid volume deficit? Yes, because I am losing fluid. So when you think about this, do not memorize lists or bullet points, but understand how this could occur. Okay? All right. Signs and symptoms. Again, you're not going to memorize this. You're going to think about it. Well, let's see. If my output is greater than my input, would it make sense that I would have a fluid volume deficit? Well, sure. If I'm putting out more than I'm getting in, it makes sense. If I have weight loss, if I have loss of skin turgor, okay, all of these are signs and symptoms. Why would I have a dry mucous membrane if I had a fluid volume deficit? Because I have no fluid, I have no moisture, right? Increased body temperature. Our body uses water as a coolant. So if I run fever, it's going to use more water to cool me off, so therefore that puts me at risk for fluid volume deficit. So I hope that you're following me here and that you're understanding what I'm telling you. It's important that you understand these concepts. Do not memorize. Okay? Other things on there. Does it make sense that I would have an increased heart rate? Of course. Decreased blood pressure? Of course. If I don't have any volume in my vascular space, then my blood pressure is going to go down. So that makes sense. Elevated serum sodium. Your labs, they're going to be more concentrated whenever you have a fluid volume deficit, because if you lose fluid, if I take a couple mils of a solution and say it has 4 particles in 2 mils, well, if I take one of those mils away, the particle in there is still 4, so my concentration is now higher to the amount of fluid that was in there. So what are we going to do about fluid volume deficit? Well, first and foremost, we have to treat the underlying condition, because we may be able to give them an IV and put fluids in them, but if we don't fix the underlying problem, it's not going to matter. They're going to be right back in the same place. So we'll need to administer IV fluids, and we're probably going to give them isotonic, sometimes hypotonic, and we're going to talk about these different fluids shortly and help you understand which fluid you would give your patient. But what are you going to do? We want to avoid anything that is going to deplete them of more volume. Water volume. We don't want them drinking caffeine. We don't want them drinking alcohol. avoid over exercising in the hot weather. Okay, we may end up having to give them tube feedings or TPN through an IV. All right, so it's just, what are we going to do? Oral hygiene is a big one with patients with fluid volume deficit. Their membranes are so dry, and we want to make sure that we're addressing that as well. Fluid volume excess, that would be just the opposite of what we just talked about. That is holding on to water in our extracellular fluid, and that causes water to move into our cells. This is when we have hypervolemia, or we could have hypervolemia, and that just means excess volume. Okay, that's about a 5% weight gain. Rule of thumb is more than 2 to 3 pounds in a 24-hour period. That's whenever we would start to be worried about volume excess. And I'm going to tell you right now, your first, foremost, number one best way to determine fluid volume excess or fluid volume deficit, it's a shift in fluid volume, is weight. Number one way to determine fluid volume up or down is daily weights. Okay, so what could cause it? So let's just think. Put your thinking cap on. Just think. What could cause me to have too much fluid? Well, if I drink too much fluid, number one way, right? Would that make sense? If you overflow my cup runneth over. I have too much volume, so I'm going to have excess. Excess of sodium, because we know that where salt goes, water will follow. So if we're taking in too much salt, we may retain water. Renal failure, congestive heart failure, again, these are the disease processes that don't allow us to function properly, and so we retain fluid from this. Giving large amounts of fluids rectally also could cause that. So what would we see in a patient who has fluid volume excess? All of these things on here. Pulmonary edema. Would it make sense that if my heart is not pumping correctly and I'm not getting this fluid, you guys remember how the fluid goes through the heart and into the lungs, back in the heart and back into the body, that if I have pulmonary congestion, if I had congestive heart failure, which is under the cause there, and my heart's not pumping properly, would it make sense that I would have a buildup of fluid in my lungs? It would make sense to me that I would have too much fluid in there, and that would be pulmonary edema. If I get on the scales, are they going to be up or down? Well, if I have too much fluid, it's probably going to make me heavier, so it would be a weight gain. If I have a lot of fluid in my lungs, and you are my nurse and you listen to my lungs, what are you going to hear? You're going to hear rails or crackles. Okay, I have fluid on board. So if you're my nurse, you're assessing me and you hear that, then that should be a clue to you that I have too much fluid going on. Maybe I've got too many IV fluids pumping in me. And then, of course, treatment. The same as with the deficit, you definitely want to fix whatever the problem is. The first and foremost is your underlying problem. You may need to limit fluid intakes. Maybe you've diuresed them out too much. You might need to cut back on your diuretics. You may give them fluids, a hypertonic solution, which we will talk about these solutions here shortly, but you may see hypertonic solution given, and that would be in a case of water intoxication. Okay, so when you read these, again, think about why these would occur with this process. Okay, so let's talk about electrolytes for just a second. There is a table in your book that has all these electrolytes in it. You are responsible for knowing these electrolytes. Okay, so I don't know the name of the page or the page number off the top of my head. I will give you that in class, but in your book you can look in the index and look up these electrolytes, and it'll take you right to that chapter that you're supposed to be reading for IV therapy anyway, and you can flip through there and find the electrolyte table on there. Sodium, potassium, and magnesium are the ones that I have on this slide and that I'm going to briefly hit, but you are responsible for all of them, so make sure that you get on there or get in your book and look at those. you have to know lab values. It's just there's no shortcut out of that. You have to know that sodium lab value is 135 to 145. It's a memorization. Okay, it's a number, it's a fact. There's nothing we can change about that. Now, understanding what those lab values mean is a whole nother ball game. So when this is going to make more sense to you after we have lecture in class. But this is the way I want you to think about this whenever you're studying. Hyponatremia. Okay, hypo means low, and hyponatremia would be low sodium. That is a deficit in our blood. Okay, so it's low sodium in our blood. And as you're reviewing these, the same thing with hypokalemia or hyperkalemia, hypermagnesemia. Think about it in this way. Don't be trying to memorize bullet points and what, okay, hyponatremia. It is caused by ... And I'm going to see ... Okay, you need to be thinking about this in a way of, if I have hyponatremia, which is a low amount of sodium in the blood, how do fluids shift from the intravascular space to the cell, or vice versa, from the cell into the intravascular space? And again, this will become more clear once you hear the lecture. And after you hear the lecture, when you're studying this table, this is what you need to think about. If there's a low volume in the blood, then that means that fluid could shift from the intravascular into the cell. And if fluid gets too excessive in my cell, what's going to happen to that cell? It's like filling up a balloon. It's going to keep growing and growing, right? And think about this. My brain is made up of cells. And if those cells in my brain continue to swell, would it make sense that I would have cerebral edema? And what happens when we have cerebral edema? We know that we could have seizures from that. So by looking at this slide and thinking through it in that process, does this make sense? And that's the way that I want you to view each one of these. In the same manner, if I had hypernatremia, which is an excess in the blood, which could be caused by an excess of sodium or loss of water, okay? Either way, if I have an excess, that means that I'm going to have a shift of fluid into the vascular space. Well, if fluid comes from the cell into the vascular space, what's going to happen to that cell? Well, it's going to shrink, right? So would it make sense that if my brain cells are shrinking that I would have CNS effects? So think about it like that. No memorization, but understanding why and how these work. And do that for each one of these electrolytes. And again, make sure you review it in your book. Okay, so now we're on to these types of solution. A lot of what I've just talked to up to this point hopefully is a bit of a review. The types of solutions, the isotonic, hypertonic, and hypotonic. Those are the three that we are going to talk about. Alright, so isotonic solutions. They are as close to our normal body fluid as we can get. So isotonic is close to our own body makeup. The osmolarity is 275 to 295. Remember earlier I told you that our homeostasis, or what our body always wants to stay at, the osmolarity or the pulling power, is 275 to 295 milliosmoles. So it would make sense that if isotonic is as close to the body composition as we can get, that the osmolarity of that solution would also be between 275 and 295. Alright. It stays in, if we give an isotonic fluid to our patient, it stays in the intravascular space. Okay. It is just like replenishing loss that we would have. Alright. Examples of that, the biggest example that you'll see in facilities is normal saline. That is an isotonic. Another one is lactated ringers, and that one's used in surgery a lot. But LR, or lactated ringers, and normal saline are the two biggest isotonics that you will see. Now you also see on there, as on your slide, that I have D5W in the bag. That is considered an isotonic fluid, but we're going to talk about it as a hypotonic fluid here in just a bit. because in the body it actually acts as a hypotonic fluid, and that's what we really care about, is what it does in our body. But I just wanted you to know that you may see this classification as isotonic, but the action that it has on the body is hypotonic. Okay, so I put pictures on each one of these slides, and some of them look kind of similar, but make sure that you read them. It will help you to try to understand how these fluids shift and why you should give one versus the other to your patient. Okay, so indications for an isotonic fluid. Why would we give our patient an isotonic fluid? Why do they need normal saline? Hypovolemia, and we know that hypovolemia is low blood volume, right? Our extracellular volume needs to be replaced for, I don't know, perhaps for major blood loss, hemorrhaging, or if you have severe vomiting. Okay, we just need some fluid replacement is what's going on here, and that's why we would give an isotonic fluid. If we have low blood pressure, you may have a fluid bolus that is given. Dehydration, we use isotonic fluids a lot of time, like for piggybacks and stuff in the hospital. Whenever pharmacy mixes drugs, we'll use the isotonic solution to put those in. We use other solutions because we use a lot of dextrose solutions as well. For initiation of blood products, and you guys will learn this more when we have our blood lecture, but it is the only fluid that you can hang with a blood administration, and that is normal saline. Burns, fluid loss from diarrhea, vomiting, anything that we just need to replace some fluids, that's when we would give an isotonic solution. So what would be a complication of an isotonic solution? Well, too much fluid, right? So if you have a glass that is half full and we want it all the way full, if we turn our head for a minute to watch TV and we just keep pouring, it's going to overflow, right? So that's kind of what would happen with this isotonic solution. So we would have extracellular fluid volume with that. We want to make sure that we watch when we have patients who have diseases such as congestive heart failure or CHF because of the increased volume. And you guys will learn about CHF in med-surg too, but that's whenever our heart is not functioning properly and the fluid would back up into our lungs, and that could cause pulmonary congestion. And so we don't want to put too much fluid on board, especially if they're at risk for that. And you also need to know that too much fluid can also dilute your labs out, and it could make you have a diluted concentration of your hemoglobin and your hematocrit. So whenever you're reviewing labs, you just need to be aware of that. Hypertonic. Okay, we already talked about the osmolarity of the isotonic, and we know that those numbers are between 275 and 295. So if my number happened to be over that, would it make sense to you that I have a greater osmolarity, and that is a hypertonic solution? Okay. With hypertonic solutions, the water moves out of the cell and into the vascular space. And if I have fluid that moves from the cell into the vascular space, that would make my cell shrink. Okay, so that's what's happening if I administer a hypertonic fluid. And again, I'm going to draw pictures of this in class and try to make this a little bit more clear. If I draw fluid from the cell into the intravascular space, what is going to happen to the volume in my vessel or in the intravascular space? It's going to go up, right? So it would cause an increase in the vascular volume. Examples of hypertonic solutions: there are many solutions of all of isotonic, hypertonic, and hypotonic. These are just some pretty common ones that you may see. D5 normal, D5.5 normal, D5LR, a 3% or a 5% normal saline, and those are usually what you would see with a patient with water intoxication. Okay, your TPNs, those are hypertonic. Albumin, those large molecule protein molecules, those are hypertonic solutions. Those are all examples of that. So why would we need to give a hypertonic solution to a patient? Well, we may need to just give them some nutrition. They may need calories. Um, they may need ppn. I just talked about reversing water intoxication, and that's because that draws water from the cells. So if we have water intoxication, and that's where you guys have probably talked about this in mental health, so, like schizophrenia, it's part of the disorder, and they will literally drink themselves unconscious or to death. They just have this thirst for water, and they will drink and drink and drink. And so they have all this fluid on board. Their cells start to swell, and if I have cells in my brain that start to swell, what's going to happen to my brain? Eventually, it's probably going to herniate. So if I have brain swelling and I'm trying to get fluid out of those cells in my brain, I could put an IV in me, put a hypertonic solution in, and that hypertonic solution is going to draw the fluid from the cell into the vascular space. And then we would probably give, well, it would depend, but we could give something to, like diuretics or something, to flush that out. And I'll give you more examples in class, but that's how a hypertonic solution works. It goes into the vascular space and it draws fluids out of the cell into the vascular area. Let's go on to the next slide. Hypertonic complications. Well, if I'm drawing fluid out of the cell, then what would happen? I could get intracellular dehydration, right? Because if I have a rapid loss from my cell, then I would have intracellular dehydration. But because I'm pulling fluid from the cell and it's going into the vascular space, what could happen? I could have overload there, and we know that the vascular space has blood that goes to my heart and into my lungs, so it could cause congestion in my lungs. So I could get pulmonary edema from a hypertonic as a hypertonic complication. So when you're thinking about these fluids, make sure that you're thinking about along those lines. Would it make sense if I gave this fluid? What is it going to do to the fluid shift in my body? Is it going to take fluid from the cell and put it into the vascular space, or is it going to take fluid from the vascular space and put it into the cell? And if that occurs, what types of complications would I have on either end of that spectrum? Okay. Hypertonic fluids, things that you need to know, they have to be given on a pump to make sure we are preventing any type of pulmonary congestion or heart overload. Making sure that we give a maximum of 220 mils in a 4-hour period. Okay, so that we don't overload our patient. And then the last type of fluid that we'll talk about is the hypotonic, and this osmolarity this is the low end, so it would be below 275, because again, remember the pulling power, the normal osmolarity was 275 to 295. And this is when water moves into the cells, and if we have water that moves into the cells, that means that it's going to swell. Examples of hypotonic would be half normal, 0.33 normal saline. And then I told you we would talk about the D5W. And in the bag, again, it's isotonic, but in the body, it's hypotonic. Okay, D5W doesn't contain any sodium, so it depletes the sodium in the serum, and it causes it can cause brain swelling. Okay, that dextrose in that solution is used up very quickly, and so that's why it's considered hypotonic, because it's used up almost immediately. So why would we need to give our patient a hypotonic solution? Well, dehydration, right? We would want to give it for that, because what does the hypotonic solution do? When we put hypotonic solutions in our vein, in our vascular space, then it is going to shift fluid into the cell. So if we have cellular dehydration, this is what we would want to do to try to fill those cells back up. Okay, it corrects our fluid loss from sweating too much, or maybe we've suctioned too much out from an NG. Alright, it also can promote urine outpatient in a dehydrated patient. So we want to make sure that we know the reasons why we would give each one of these fluids, because hopefully at this point you can understand why giving the wrong type of fluid could really be catastrophic for our patient. And then hypotonic complications. What could be problems with this? Well, if we're taking fluid from the vascular space and we're shoving it into the cell, then we could have swelling of that cell, right? So we could have water intoxication. We could have brain swelling, which is not something we want. We could have worsened hypotension. If I have a patient who has low blood pressure and we give them a fluid that is going to take more volume from the vascular space, then we could make that situation even worse on our patients. And the big thing again is to watch patients who have increased intracranial pressure, because that brain swelling is a huge deal, and once you have a herniated brainstem, there's no taking that back. Okay, so overall, just assessment of fluid volume. We use INO a lot. That's a very good tool that we use, but the number one thing that we use for assessment of fluid volume is our weight. We weigh our patient. We know that 1 liter is equal to 1 kilogram of weight. 1 liter of fluid is equal to 1 kilogram of weight. You need to know that. You need to know that today, tomorrow, and for the rest of your nursing career. Weigh your patients the same time every day. We usually do that first thing in the morning, and make sure that they wear the same clothing every day. Okay, no swimming suit today and Alaska parka tomorrow, because it's going to make a huge difference. So we try to weigh them in the same clothing. Other assessments that we use: thirst. We know that our hypothalamus stimulates our thirst whenever we have a decrease in our extracellular fluid. Our blood pressure, we monitor that. We know that if we have a drop in our pressure, that would mean we have a fluid volume deficit. And on the other side, if we had an increase, that could mean we have too much fluid on board. Our hand veins, our hand veins should be empty whenever we're holding up our hands. They should fill whenever they're lowered in about 3 to 5 seconds. Neck veins, they'll be slightly distended when you're lying flat, but by the time you raise up to about a 45-degree angle, that should be gone. If you still have distended neck veins past a 45-degree angle, we've got too much fluid on board. Skin turgor, we always check with that. Normal recoil is about 3 to 5 seconds. It'll be increased if we have a deficit. The hand's not always the best to test on the elderly, and we know that, just because of their skin. So you might want to check a different place on them. Lungs, what are we going to hear? Again, I've already told you this: rales, crackles, pulmonary edema in the lung space. Specific gravity, that's our concentration of urine. Normal specific gravity, I believe I have that on there for you, is 1.005 to 1.030. If we have low urine output and a high specific gravity, then that would indicate that we have a fluid volume deficit. There's not enough fluid on board. But if we have a low urine output and a low specific gravity, then that indicates that we may possibly be having renal disease. So you'll want to watch your labs with that as well. So assessment is a big piece of this. And I know that this seems like a lot. Students traditionally struggle with the fluids lecture, but we're going to talk about this in class, and if you have any questions, don't hesitate to contact me, and we'll do activities to make this become clearer for you. And that's it for your fluid volume lecture.